Hi class, this is my presentation for recorded PowerPoint for week 9. The topic I chose to present on is vaginismus. So epidemiology and risk factors. This occurs due to an involuntary spasm of the muscles that surround the vagina, making penetration painful or impossible. The prevalence in the clinical setting of vaginismus ranges from 5 to 17%. Psychosocial factors are believed to cause vaginismus, such as lack of sexual knowledge, sexual guilt, negative attitudes towards sexuality or sex before marriage, strict religious upbringings, along with depression or anxiety issues, and then a history of abuse can also play into this as well. Potential causes. So congenital abnormalities, acute or chronic inflammation, vaginal atrophy, like I mentioned before on the previous slide, anxiety, depression, lack of sexual knowledge, those can all play into, causes and risk factors for vaginismus. So there's two categories for vaginismus, primary and then secondary. So primary, the patient has never experienced non-painful intercourse, and then secondary, the patient has previously experienced non-painful intercourse but subsequently experiences pain. And then subjective findings for the patient. Painful intercourse, dyspareunia, penetration being impossible or difficult to achieve. Tightness and pain can sometimes be described as burning or stinging by the patient. Pain or tightness with tampon insertion, pain, tightness during routine GYN exams, and then long-term sexual pain with or without known cause. Objective findings, and then the classification system. This was laid out in our book, and I really wanted to put it in here as when we're doing our assessment for objective findings for patients with vaginismus. This is something that we really should look to, and this gives us a really good, grading scale on what to look for and how to grade them as far as how severe the vaginismus might be. So Lamont grade 1, patient can relax for pelvic exam. Grade 2, patient is unable to relax for the pelvic exam. Grade 3, buttocks lift off the table, early retreat, and the toes curl upward. Grade 4, generalized retreat, buttocks lift up, thighs close, patient retreats as well. And then grade 5 was added onto this as well. Generalized retreat plus visceral reactions such as, things like palpitations, hyperventilation, sweating, shaking, hysteria, screaming, nausea, vomiting, potential desire to attack the provider. So a lot of these things can be, looking back at risk factors. So history of abuse, lack of sexual knowledge, anxiety, depression, these can all play into, patients that have vaginismus. So differential diagnoses, dyspareunia, vaginal atrophy, vulvodynia, sexual arousal disorder. Diagnostic testing. So really diagnosis of this is based on subjective and objective findings during the assessment of the patient, really doing a good and thorough physical exam along with, what the patient's telling you that can, be the diagnostic and diagnosis criteria for vaginismus. Potential abnormal findings. So potential abnormal findings for vaginismus may relate back to any of the differential diagnoses or potentially finding an infection or possibly imperforate hymen. So those congenital abnormalities can definitely play a role in vaginismus as well, if not known before. Care plan. So non-pharmacologic and pharmacologic. So there's not really too much that can be done. There really isn't really a broad spectrum of things, but there definitely is care, plan of care to help these patients. So pelvic floor therapy, CBT, hypnosis, counseling, talking to, therapists and things like that about anxiety, depression, if the patient does have history of abuse, lack of sexual knowledge, sex counselors, potential marriage counseling and things like that, that can help the patient. And then pharmacologically, local and topical anesthetics like lidocaine might be able to help the patient either relax for the GYN exams and sexual intercourse as well. Lubrication, definitely, advocate for that. Water-based lubricants, muscle relaxants such as Botox, they do injections that can help to relax the muscles and really have the patient, be able to achieve that penetration. And then again, medications to treat anxiety and or depression if needed. This might be playing a role in vaginismus as well. And then education and health promotion. This kind of goes along with what I was talking about in the last slide. There's a multimodal approach for treatment. This is recommended for best outcomes. Treatment may be needed over a long period of time, like 5 to 8 weeks for best outcomes. Like I mentioned, they might include the Botox, also progressive dilation under conscious sedation, that might be needed as well, indwelling dilator therapy, working their way up as far as dilators and things like that. The patient really, they need to be willing and able to participate fully in the treatment plan as described on, the previous slide with pharmacologic, non-pharmacologic interventions, and being present at these appointments and really wanting to, fix this and solve this issue. So like I mentioned, psychosocial needs, referrals for the patient, sex therapy, marriage counseling, individualized therapy for patients, should all be considered when creating a plan of care for them. Therapists, counselors, pelvic floor, Botox specialists, that specialize in, treating patients with vaginismus, things like that, should all be completed and researched for the patient. And then here are my references. Thank you.